afternoon, everyone. Welcome to our Families USA Health Action webinar, Protecting Health Insurance Consumers at the State Level. Today we're going to talk about how states can take action to protect health insurance consumers and the markets from a number of issues that we're facing coming down from the federal level, like sham short-term health insurance plans and association health plans, and other recent threats that we see coming through federal regulation. These are really acts of sabotage, and it's now on states to protect healthcare consumers and the health insurance markets from them. I'm Claire McAndrew. I'm the Director of Campaign Strategy here at Families USA, and I'm just going to go through our agenda for today's webinar. Today we're going to start hearing from Cheryl Fish-Parcham. She's the Director of Access Initiatives here at Families USA, and she's going to talk us through these current threats that we are facing based on federal rulemaking. Then we're going to hear from our partner, Danya Palanker. She's a assistant research professor at the Georgetown Center on Health Insurance Reform, and she's going to talk more specifically about what states can do to protect consumers and health insurance markets from the damage of short-term plans. And then finally, we're going to hear from our partner, Kathy Agoura. She's the Director of Health Reform at EverThrive, Illinois, and so she'll be able to speak to some lessons from the efforts that she and her allies in Illinois are engaging in right now, and speaking to those efforts of how they're trying to stop the harm of short-term plans in their state. And so we'll take a few questions after each speaker. We're going to take all questions through the chat box that you can access on your computer, so feel free to start putting in questions at any time as they come up. And then at the end of the call, we'll have a bit of a longer dialogue. So with that, I'd like to introduce my colleague, Cheryl Fish-Parcham. Again, she's the Director of Access Initiatives here at Families USA. She is a real expert on the private health insurance market, and so she'll be walking us through the current threats that we need to be aware of in the market for consumers as these federal regulations are changing. So Cheryl, thank you so much. Take it away.
Thank you. So I want to review some of the threats that you may have been hearing about in a different context in the last few months, because now we're talking about federal rules that have either been finalized or can be finalized, and what's left at your state level to protect consumers. So when I talk about it being a good time to talk to your state officials, there's a variety of state officials you could talk to. You can talk to your state insurance regulator, your insurance commissioner, that is, the state legislatures. If you're a state that has a healthcare ombudsman or an advocate, you can talk to them. And your first step is to find out what concerns they share. The first issue we're talking about is short-term plan rules, which could be finalized in the next few months. And if they are at the federal level, they'll increase the sale of junk insurance. They will allow, under the federal proposal, plans could be sold for up to a year and renewed at the insurer's discretion. But as we've talked about before, short-term plans only provide an illusion of coverage, and people who buy them are often surprised at just how bad they are. They may compete with and undermine ACA-compliant plan sales, and Wakely estimates that sales of short-term plans could increase the prices of full benefit plans that are compliant with the ACA by as much as 1.7% the first year, and by as much as 6.6% in future years. So the Kaiser Family Foundation recently released a study showing how many short-term plans have gaps in terms of essential health benefits where they don't cover a whole category of benefits at all. And you'll see on this slide that none of them that Kaiser reviewed cover maternity care, and only 43% of them cover mental health. So they're a long way away from reaching the goals that we all had in the Affordable Care Act. Besides these major benefit exclusions, they also have fine print exclusions that you may not see. And states, when they, many years ago, started writing laws saying plans have to cover X, they often excluded short-term plans from all of their state rulemaking. So now is a good time to revisit that, because these plans may be sold in greater numbers. So some examples of fine print exclusions that I saw in different policies was one policy covers substance abuse, but it doesn't cover any injury that results from being under the influence of alcohol or drugs. A plan says it won't cover tonsillectomies or hernia repairs for 6 months after purchasing the policy, even though under current rules you shouldn't be able to buy this policy for 6 months. It's only supposed to be sold for 3 months. Some of them say they won't treat interscholastic sports injuries, so you can imagine a mother sending her kid to soccer and being very surprised that it's not covering the kid's concussion. So these are dangerous. And so you might want to think at your state level, should these exclusions be allowed? And if they are allowed, should at least consumers be warned more about them? Is that something you want to work with your state about? Another reason to talk to state officials about short-term plans is that they may cover very little compared to the actual prices that consumers face. And an example of that comes from D.C. There was a consumer that the healthcare ombudsman here helped who had a heart bypass surgery that cost about $200,000. The plan, even after negotiation, only paid about $11,000 of that bill. Can you imagine being left with a $190,000 bill when you thought you had insurance? That is unconscionable. So the reasons that this happens is that sometimes plans have annual maximum benefits that consumers aren't aware of. They have daily benefit ceilings, and these may be transparent in the policy. They say they pay $1,000 a day of inpatient care, but you don't really know as the consumer what does inpatient care really cost to realize that that is inadequate for your needs. They might not have any provider network that accepts their prices. And they have a lot of pre-existing condition exclusions, including, and there might not be any state regulation about how they define a pre-existing condition exclusion. So in this case, they thought that the consumer should have known that he was at risk for heart disease because of his family history. Well, that's a very weird pre-existing condition exclusion, and should that be allowed? And that's something you want to talk to your state about. The next issue is association health plans. And again, the rules aren't finalized about these yet, but we know that federal rules have been proposed that would let these plans be sold to sole proprietors and very small businesses. And in the past, there has been a long history of insurance fraud in association health plans. And you might want to talk to your regulators about, are they aware of insurance fraud in your state in the past? Are they concerned about it if this proliferates for small business owners and sole proprietors? Because one of the protections in association plans is that they're supposed to have a fiduciary who's responsible for making sure that the plan is solvent. But you get a bunch of small business owners together, and they probably don't have the financial expertise or the time to oversee their plan. So you want to make sure that your state has the power to do it. And so you may want to, we don't know yet whether federal rules will allow states to fully regulate these plans or not, and that's what states have written to the federal regulators about, and we'll see what happens. A next issue to talk to state officials about is essential health benefits. And these rules have already been finalized. Beginning next year, a state might really change the depth of benefits that it requires marketplace plans to cover. And they have 4 options. They can retain their existing benchmark. They can use another state's benchmark that might not be as generous. They might allow substitution of one category of benefits. They might develop an entirely new benchmark. So this is about how much and what kind of services within the 10 categories of benefits each plan has to cover. There are some protections, but you want to get in right away to find out, is your state really planning to revisit what benefits get offered? And if so, is there an advisory committee, or how can you be involved in the process to make sure that benefits that matter to patients will be covered? The last issue that I'll briefly mention is one that's on the agenda right now, because in the coming week we're going to start seeing announcements of proposed premium increases for 2019. And the federal rules, which have already been finalized, weaken the standards of review, but states can retain stronger standards for review. So, for example, under the federal rules, the rate review threshold could be increased so that states could say, we'll only review rate increases that are more than 15%, but states could keep to a lower standard and say, we're going to review all rate increases that are 10% or more, or even all rate increases entirely. So you want to make sure that your insurance department is using its authority to review rates that might be excessive. Insurers or states can also ask CMS to change the rules about how much of premium dollars go to direct medical care. They might ask for a waiver of that provision and let insurers keep more money in profits. And you want to make sure that your state regulator is not doing that and is requiring most premium dollars to go to medical care, keeping premiums low for consumers. So those are some issues, and Claire, can you pick it up from here?
Absolutely. Cheryl, thank you so much for reviewing these threats that we're facing and that we can really make sure we take action on at the state level. I do want to mention a couple of resources that we have at Families USA that can help you walk through everything that Cheryl spoke about if you wanted to sink in a little more. The first is a piece that Cheryl wrote about the reasons that the Trump administration short-term health plan regulation would be so harmful to consumers. And so I encourage you to take a look at that on familiesusa.org. And I want to mention, too, that we will be circulating resources after this webinar as well. The second piece I want to mention is a piece that Cheryl and I worked on together, and this covers some of the other issues that Cheryl spoke about, threats to the essential health benefits package, the threats that Cheryl spoke about related to medical loss ratios, as well as rate review. And then another thing I want to mention, too, is that network adequacy issues have been coming up because of these rules. A lot of folks I know have been working with their state legislators, their state regulators, to make sure that there is adequate protection so that when someone buys a health insurance plan, they can actually use it to see the doctors and go to the facilities that they need to get care. And it was very helpful before that federal regulations used to set some standards that every single state's health insurance exchange, whether it was a federal exchange or a state exchange, they all had to comply with this. Now, over the past couple of years, these federal standards have been unraveled such that even if you're in a state that has a federally run exchange, it's completely up to your state to regulate network adequacy. So that's another issue where you want to speak to your state officials and make sure that your state has adequate laws there. So we'll circulate these resources after. And Cheryl, thank you so much for walking us through this. And now that we've heard from Cheryl about these threats and some initial actions that you might want to take in your state to protect against them, we're going to dig in a little bit deeper on what states can do to protect against the harms of short-term plans. And so to walk us through that, we're joined by Danya Palanker, a wonderful partner of Families USA, who is an assistant research professor at the Georgetown Center on Health Insurance Reforms. And Danya, thank you so much for walking us through what more states can do and have done so far to protect against this threat.
You're welcome, Claire. And so on the next slide, I'll start. I'm going to start mostly talking about state options for short-term insurance. But we'll also talk a little bit about some options that states also have around the association health plan rule when that comes out, or before, to prevent changes once that does come out. So particularly on the short-term side, states have a wide range of options. States are the primary regulators of insurance, and that means they're the primary regulators of short-term insurance. The federal regulation that Cheryl talked about really does, in many ways, very little. It's really just defining for federal purposes the length of the plans, whether or not they can be extended, and the notice. But there's a lot of pieces around consumer protections that can still fall to the states. So pretty much, this list here is pretty much any type of regulation a state has that it applies to insurance can be applied to short-term insurance. And they can really make sure that these plans have stronger protections, including compliance with certain provisions in the state that already apply to the individual or small group market. And then regulators also have broad enforcement tools in addition to trying to pass new laws that would provide protections. that there's a lot of current enforcement tools they have around examining the practices of the insurers, making sure they are looking at the form filings, and if necessary, taking action against any carriers that are violating the state's law. There actually was a recent settlement announced against one insurer, HCC, by a number of states that had worked together and through market conduct examinations found that this insurer was violating numerous laws. And part of that settlement is both paying fines and also the insurer will not sell new short-term plans for at least 5 years. So there really are strong enforcement mechanisms states have to make sure that these insurers are at least complying with the existing state law. So the next slide goes through how states can pass new laws to protect market stability. And I'm doing that by, what I'm going to do is talk through some laws that exist in the states already, most of which were passed a long time ago. Actually, most of these are not new actions. And then I'll also talk after that about some legislation that's moving, and then provide a little more detail in some examples of state laws that really can, I think, be some good examples to look at. So first, states can ban these plans outright. No states have a very clear ban in their statute, meaning no states say short-term limited duration plans cannot be sold in this state. However, California is considering such a law, and actually not listed here, but Hawaii is also considering a law that kind of effectively bans the sale of these plans. There are 3 states that effectively ban their sale, New York, New Jersey, and Massachusetts, because they take all of the requirements for individual insurance market plans. They all apply to short-term plans. And this was really part of the health reform they did in the 1990s, the insurance reform in those states. But basically, these states just don't mention short-term anywhere in their statute, which means there's just no possibility for them to exist unless they were to meet all the requirements of individual market insurance. So those 2 are sort of the most comprehensive way you can limit these plans, really, by having these plans that not exist in the state. But it's also possible to take select individual market rules and apply them to the state, to the short-term plans. For example, Rhode Island requires coverage of pre-existing conditions in short-term plans. And then a number of states require coverage of some state mandates, but these states listed here require coverage of all state mandates. Although no states require coverage of the essential health benefit. So are the state-specific mandates, not the ACA benefit mandates. And requiring coverage of state mandates does not seem to really limit the sale of these plans, but it at least is somewhat boosting the benefits. If any state that has an individual mandate for maternity were to require all state mandates be covered, then we would have at least one state where maternity was covered in these plans, for example. So on the next slide, I walk through some more examples. First, a number of states limit contract duration and renewability more strictly than the proposed 12 months. There's a lot more states that actually define short-term plans to 6 months or somehow have a limit to 6 months. But these states have a limit to 3 or 6 months and in some way limit the renewability. I'll walk through Maryland and Oregon in a little more detail later, so I'm not going to get into detail on that right now. And then Rhode Island also requires that short-term plans meet the medical loss ratio that we have in the ACA for individual market plans, which really is a strong disincentive for these plans to exist because the amount of time that of the contract duration is so short, and they really are designed for healthy people that you can imagine a lot of money is going into the administration and profit side rather than in paying claims. And although we haven't seen it yet, another option that states can look into is if they have a reinsurance program or are proposing a reinsurance program is to make sure short-term insurers pay into that. So if they are taking healthy risk out of the exchange, they should pay towards that reinsurance program for that money to go back to the marketplace insurers. And of course, states can do a combination of above, and Rhode Island was mentioned in a few, and as a result of this, there actually are no short-term plans sold in Rhode Island right now. So it's possible that putting together enough protections might push insurers out of the market totally. So the next slide just mentions some states that are currently considering state legislation. And I'm not going to get into too much detail, but I'll notice it goes from California, which is actually considering banning, to states that are looking at limiting the duration to basically 3 months. So if the federal regulations are finalized as 12 months, the plans in those states would be 3 months. And in some ways a little stronger by preventing them from being renewed or rescinded. But there are also 3 states, Minnesota, Missouri, and Virginia, that are looking to lengthen the duration to 12 months that currently have 6-month limits and are actually looking to mimic what the federal government appears to be doing. So not all action at the state right now is to protect the individual market from short-term plans. Some states are actually looking at expanding access to short-term plans and making them be longer. On the next slide, I walk through Maryland, which is the only state that has this year passed a law that limits short-term plans. And the way they did this was they changed the definition of short-term limited duration insurance. So the policies are limited to under 3 months. They cannot be extended or renewed, which is very important because if you have a 3-month limit and someone can just extend that with the insurer, then it really doesn't become a 3-month limit. They also apply the same underwriting standards to all applicants. And they have a notice requirement, although the notice requirement is pretty much matching the federal law, so it's not really going above and beyond. States could, if they wanted to, use a notice requirement that goes above and beyond in explaining what things are not covered under the plan, as well as if a state were to implement a state mandate, they could mention specifically that it's not qualifying coverage or minimum essential coverage for the state mandate. Those are types of things that the state could do. And on the next slide, I talk about Oregon, which passed a law in 2017 to bring the state to codify the existing federal regulations. And they also went a little further. So the Oregon law limits the duration to 3 months or less, including renewals. And importantly, they note that a renewal includes a contract that's issued by the same insurer within 60 days of a short-term plan ending. And this is a really important piece because something that has been happening since the 2016 regulations is that some brokers have been marketing to people to buy 4 short-term plans with staggered start dates at the same time in order to have 12 months of coverage. So they've really had this loophole to the limitation, which is that people can just buy 4 plans that start 3 months apart and have almost a full year of coverage that way. And so Oregon prevents that. It doesn't necessarily prevent an individual from going to another insurer at the end, but it does prevent one insurer from issuing 4 consecutive plans. On the next slide, I get into information on Oregon, which is what I include them because they have a limit on the amount of time an individual can enroll in short-term plans. And it does allow an individual to be enrolled for up to 12 months. On the next slide, you can see the details, but it does not allow that person to then go into that 13th month. And a state could model something off of this that limits to 3 or 6 months total enrollment, and they require the plan to ask questions and note that if you answer yes, the policy cannot be issued on the application in order to actually be able to enforce this. And then on the next slide, I do list some other ways that, that states can protect consumers. An important piece is to monitor this market so that, particularly the marketing, so that states are responding if there is overly aggressive or deceptive marketing. To increase the capacity of the consumer complaint divisions. Right now, this is a very small market, but we are expecting that it will grow because a lot of insurers are getting the message that the administration sees these as a replacement for longer-term coverage, so they might grow. There might be more complaints. And then also just making sure that consumers have information and are able to exercise their appeal rights. And now I want to shift briefly to association health plans. And so the next slide, on state policy options, they are going to depend on what the final rule does. And I think there's a lot more clarity about where we think they will go on short term than association health plans, which is a much more complicated rule. And a big issue depends on whether the final rule preempts state regulation. Now, it is possible that the final rule is going to clearly state specific types of regulation that it is preempting or preventing from the states. It is also possible that the final regulation will clearly say states continue to have the same authority and that this does not preempt any state regulation of association health plans. And then there's this third possibility, which is they're silent, which could actually create some uncertainty because there could still be an ERISA preemption if a state somehow regulates association health plans of the employer plans more strictly than the federal government. It's possible if it went to courts, the courts would say that that is preempted by ERISA because the federal government has regulated here. And so there's a possibility we will be down the line months or years to know, unfortunately. But an important piece to know is regardless of what the final rule does, states should be able to retain authority to regulate financial solvency of associations and multi-employer welfare arrangements. And this is important to protect the insolvency that happened in the 70s and 80s with these plans. And on the next slide, talk a little more about what really they can do if preempted is they can require association health plans to meet the same solvency and governance standards as other carriers. They can require contributions to state guarantee funds, and they can also clarify or enact state law that allows insurance departments to place an association health plan into receivership if it's needed. And this next slide I'm going to end with is that there's a lot more policy options if there's no preemption. Then states really have the full right to regulate these as they do other insurers. And the strongest example really we have out there is California that doesn't allow new multi-employer welfare arrangements, so there's only a handful in the state that have been there since the 90s. But also, basically, a state can, adopt rules that make a level playing field for association health plans and traditional insurers. They can limit membership to businesses with at least one employee, which is the current status quo. They can assess reinsurance payments to them to be able to have them contribute to reinsurance programs. And they can also require out-of-state association health plans that are offering coverage to people in state to comply with relevant insurance standards. So there are a lot of options to states on both sides, particularly if the association health plan does not preempt existing state authority. So I will turn it back to Claire. Thank you so much.
Tanya, thank you so much for all of that helpful information. It's really good to see that there are states that have actually put protections in place that can provide a model for all of us if we're advocating for our states to take action. So we're getting some questions in the chat box for Danya and Cheryl, so we're going to take a moment to talk a little bit about those questions, and feel free to enter in your questions if you have more. One of the first questions that we received is if, Danya, if you would mind explaining what it means when a state applies the same underwriting standards to a short-term plan for consumers each year, like Maryland did.
Right. So this isn't, it's not quite as strong as saying that they must apply the same underwriting standards to people enrolling in short-term as to the individual market. If they did that, that would actually prohibit excluding coverage to people with pre-existing conditions, would limit rating. It's basically just saying everyone who applies for the plan has to be treated the same. And they particularly note in the statute that they can't treat people different in their underwriting because they were already enrolled in a short-term plan. And I believe that part of this was trying to get to prevent a situation where an insurer would sort of say, well, we'll allow people to re-enroll even if they got a pre-existing condition while enrolled in order to allow people to make this a permanent insurance option if they want. So it really helps sort of keep these plans to 3 months and prevents a situation where an insurance company will just say, well, it's not a renewal, we're just giving you a new insurance plan at the end of your 3 months, and we're going to we're not going to as aggressively underwrite, so we won't push up your premiums or we won't deny you coverage, even though we would have treated you differently if you were coming to enroll at the beginning. And that, as I said, it prevents people, it reduces the chance that insurers are going to try to find a way to kind of create 12-month plans, even if the state limits them to 3 months.
Thank you so much, Danya. And backing up a little, maybe Cheryl can take this question. There was a question about where are short-term plans sold? Are they sold through the marketplace? Are they sold through agents and brokers? Cheryl, do you want to explain?
They're not sold through the marketplace. They're sold through agents and brokers. They're often sold over the web. But people who buy them over the web may not always be clear on whether they're marketplace plans or not, because despite disclosure, some of the same brokers are selling other plans too.
And then as a follow-up, Cheryl, you also talked a bit about essential health benefits and how there's different benchmark plans, but can you explain a little bit how short-term plans and essential health benefits relate to each other?
Yeah, short-term plans don't have to provide essential health benefits at all. Essential health benefits are the 10 categories of benefits that full health insurance, comprehensive health insurance plans provide in the individual and small group market. So, for example, one of the categories of benefits that they have to provide is habilitation and rehabilitation. But how much habilitation and rehabilitation and what kinds of habilitation and rehabilitation they have to provide is something that's addressed in the state benchmark. So it's how much and what kinds that is up for grabs right now, and that people should be talking to their states about.
Thank you, Cheryl. We also have a question, I think this is for Cheryl and Danya, about whether you could say a few words about the sale of short-term plans through associations and also group trusts that can evade the laws and regulations of a given state, of your home state, and is there something that states can do to prevent this?
Danya, why don't you take that one?
Sure. So, this is something we know is happening, which is there are some associations, discretionary trusts, that are selling short-term plans, and they're not showing up in any of the counts anywhere, like where regulators do try to report to NAIC at least, or to gather information on how many short-term insurers people are covered by short-term insurance plans. They're not showing up, and there are some estimates that this is a very, very big population. States do currently have some rights to regulate in the same way they have the rights to regulate association health plans. A lot of states don't strongly regulate the association health plans, though, or don't regulate association health plans that are based at a state and selling in the state. But they really can actually apply their insurance regulations to those association health plans. ERISA currently allows it for the multi-employer welfare arrangements. That unfortunately could potentially be preempted by this federal association health plan rule, so it sort of those two interact there. But right now, I think one of the most important things to do is for states, they might need to pass statute to be able to regulate these, but they should look, but regulators and other policymakers can be pushed to look at regulating the out-of-state associations as insurance providers since they're selling an insurance product in their state. And also just generally to look at what they're doing about regulation of association health plans, even within the state, and whether they're actually really making sure that they are all complying with the insurance laws of their state.
Thank you, Danya. And I'm going to give one last question to Cheryl, and then we're going to hear a little bit about how to put this in practice with different stakeholders, and we'll take more questions after that. But so for our last question right now, our colleagues in California are asking about if the state wants to increase their medical loss ratio. Cheryl talked about how states that want to lower it can go talk to the Secretary of Health and Human Services about that to get approval. But Cheryl, if somebody wants to actually make their MLR in their state more protective, for that, do they have to get permission from the federal CMS authorities?
As far as I know, no. The rule was about weakening. The last rule we just saw was about weakening MLR protections, not about increasing them. Danya, does that agree with your view?
Yes, it does.
Okay.
Yes, I think that's right too. So California folks, we're excited for you to pursue this, and hopefully you should be able to do so without having to seek permission from the federal government. And so moving on now, I want to introduce our next speaker. I know other folks have questions. We can certainly get to more after, but we really want to dive in with Kathy Agoura on how do we mobilize folks to protect against short-term plans. And Kathy and her colleagues in Illinois have been leading an effort to move legislation in the state of Illinois that would protect consumers from the harms that Danya and Cheryl discussed. And so, Kathy, we really appreciate you being here. We know you're smack in the middle of your legislative session, so thank you so much for joining us to talk about lessons for states who want to take on this issue.
Thanks, Claire, and hello, everyone. Thank you, Cheryl and Danya. Also, it was taking me back to when we started working on our short-term bill not that long ago because we used so many of the resources that you guys were involved in. So it was great to hear it all again, and my brain is spinning even though I've thought so much about this. So I am here to talk about a bill that is currently moving through the Illinois legislature to regulate short-term limited duration policies in the state of Illinois. And I want to talk, we're pretty early in the legislative process, so I can share some things about our advocacy, though I think we'll learn a lot more in the next couple of weeks. But I also want to talk a bit about our experience as advocates actually starting to wade through everything that's been presented, all of the papers and research I know we've all received over the last few weeks to actually make decisions about what to put into our bill. So Illinois advocates came together under the auspice of wanting to defend against the expansion of short-term plans in order to protect consumers and to protect the stability of the health insurance exchange. Exactly how we got there was not something we knew when we came in. We didn't know for sure. We sort of put everything on the table when it came to time frames and renewals and consumer protections and disclosures and filing, and there's sort of a lot of components. But we knew we wanted to do something that would at least defend the consumers who are purchasing insurance and the stability of the health insurance exchange. We started really by looking at some of these tools. There's the Danya talked through these state considerations. That's a paper that the Center on Health Insurance Reform put out, and that's really where we started to look at if you do one thing, what is the result, by looking at what other states have done. And so we came in pretty open. We also looked at some of the tools from Urban and Families and other places. Center for American Progress has a model bill that was really helpful to us. And there were a few things that we realized really early on. We all came to the table because we knew that short-term plans had a very limited utility, and we knew that the expansion of short-term plans threatened a lot of different things that we cared about. But as soon as we started to get into this and realized that applying even some consumer protections, as Daniel mentioned, results in no short-term plans being sold in a state, we really had to stop and ask ourselves as consumer advocates if that's something we were comfortable with, if that was a potential that we could not control as a result of legislating. So we spent a lot of time thinking about the role of short-term plans in the market. And to be perfectly honest, the advocates, it took us a while to come to a consensus. And so I want to share some of that with you. We wondered if there are folks who do benefit from having some sort of catastrophic coverage for more than 90 days. And we went back and forth to think, just because that's what the current status is that the right status? Other states have longer periods. We thought about, we had one consumer in particular who had lost her exchange coverage when her credit card was lost and she didn't update it with her carrier and she missed her 3-month grace period and now she's uninsured for 9 months. So we thought to ourselves, is she an example of someone who might need more than 90 days of coverage? And then we also thought about people who might be in transitions or whatever. And the conclusion we came to on a lot of this was that we weren't sure we could think of many people who would get a short-term plan that could not otherwise go on the exchange or enroll in Medicaid. So many of the folks we talk to, and this is true even since we've introduced our legislation, do not understand how the Affordable Care Act has smoothed coverage transitions for folks who are losing health insurance for one reason or another. And so often people say to us, well, we need short-term plans for people who graduate from college. Oh, well, actually many people are not yet 26 when they graduate from college. Or we need coverage for people who lose their job. Well, if somebody's lost their job, that might mean that they're not eligible for Medicaid. Illinois has expanded. Or it might mean that they had minimum essential coverage in their job and are now eligible for a special enrollment period. So we had a really hard time thinking of people who even would need these for a transition. Then there are women, people like the woman we had talked with. So then we had to look at what these plans actually cover. And I think it's really easy to hear people say these aren't covering the essential health benefits, these aren't covering what we see in all of the papers, but to think to yourself, well, that's okay if people are expecting catastrophic coverage. Is there a role for catastrophic coverage? So one thing that was extremely helpful for us in thinking about just how limited these plans are, and Cheryl mentioned the fine print exclusions, understanding those is crucial for answering that question. We found a document for a short-term plan that's currently being marketed in Illinois. Illinois is one of 13 states where it's sold. It is an association plan that is a partnership with United Health Insurance. And we looked at that plan, and we looked at what they say they cover, and then we went to the exclusions. There are 3 pages of exclusions, and it includes all kinds of things. I think one of the most notable for us that really sunk in how limited these plans are is it actually says they will not cover expenses for hospital room and board and nursing services if admitted on a Friday or Saturday, unless for an emergency. So that was really shocking because you can think of a lot of examples where folks can't get to their doctor during the week, so they go to the emergency room on Friday or they go to an urgent care on Friday, find out that something is wrong. It's not emergency care, but it requires hospital admission. No one expects that there's a calendar on their benefits, and so that was really helpful. Also, Cheryl mentioned some things about certain sports. This plan literally says nothing for injuries sustained during or due to participating, instructing, demonstrating, guiding, or accompanying others in any of the following. Sports. It just says sports. So we just realized that there are so many exclusions, not to mention those for pre-existing conditions, intoxication, participating in riots, which we wondered if it could be defined as protests, intentionally self-inflicted bodily harm. These plans advertise, at least this plan advertises prescription drug coverage, but the exclusions show they do not cover outpatient prescription drug coverage. So these became so limited that we realized even for folks who might actually, the very, very small number of people who might need a transitional plan, these are probably not going to pay out when they need it. And so we came to the conclusion that consumer protections, time frames, restrictions on renewals are crucial because there's, even if it might in the end result in fewer or no short-term plans being sold, because you cannot meaningfully protect consumers without those. So the bill that we ended up filing is House Bill 1337. It's a shell bill, so it's House Amendment 1, and it does 4 things. It defines short-term plans as individual health insurance. So this actually then requires the entire Illinois Insurance Code and all Illinois insurance regulation to apply to short-term plans. So this includes things like we have in regulation a requirement around essential health benefits and annual and lifetime limits. So it requires those things to come in. It was easier for us to do that than to try and write that stuff into statute. It limits the coverage period to 90 days and prohibits renewals and stacking. What Dania talked about in Oregon, we borrowed some of their language. We found we are under the assumption that most carriers are not renewing short-term plans. They're starting new plans. That also moves the target for pre-existing conditions, the look-back period. So we think that's their practice. It applies all of the protections currently in the Illinois Insurance Code to short-term limited duration plans, including a prohibition on rescinding coverage for any reason, including illness, and exclusions for people with pre-existing conditions. So those are already in our state law, and we made explicit that those will apply to short-term plans. And it creates strong filing and disclosure requirements, including extremely consumer-friendly disclosure language. We, in deciding to act on this, we're trying to understand how large the market is for short-term plans in the state of Illinois currently and what carriers are selling those plans, whether from Illinois or other places. It is not possible for us to know that. Currently, the state of Illinois has absolutely no regulatory authority over short-term plans. We filed FOIA requests with the Department of Insurance and have gotten, they have not been able to tell us what we need to know. In fact, we talked with one person at the department who said, what's a short-term plan? I've never heard that phrase before. So we wanted to make sure that there was some really good filing requirements that at the very least we could get this information in the future. So those are the big things that the bill does. I'll make a note also about the disclosure language. So the rules from the prior administration, from the current administration, have these required disclosures, and they are, they specify in 14-point font. They're all caps, and they say things like, this is not qualifying health coverage under the Affordable Care Act. If you don't have minimum essential coverage, you might have high costs. It really felt jargony. And as we talked with navigators and others, we realized that most consumers would not be able to understand what that really means. So we started to think about what a more radical idea could be for a disclosure. And we actually first thought of cigarette packs in like Australia and England. They just say smoking kills across the top, right? They don't have a Surgeon General warning like we do. It says what you need to know. So we wanted to do what we called the health insurance version of that. So we wrote a disclosure in as plain language as possible and focused less on what type of coverage it is and more on the effect of this coverage. So we wrote, warning, this plan may not cover all of the health care you need and may leave you with very high medical bills. If you buy this plan, you may not be able to get more complete insurance when this contract ends. You may be able to get more complete coverage now and help to pay for it at www.healthcare.gov. That's going to be on in a prominent place, and then we actually wrote a very short warning for every page of any material that's handed out in connection with a short-term plan. So we really wanted to think, what would it help a consumer? We also did not write this in all caps. In talking to literacy experts, we learned that a lot of people can't read words that are written in all caps. So that was pretty eye-opening for us. So it was could have and should have been a long process to get here, but because of the timing of Illinois and the timing of these rules, we started our first conversation about this bill was in mid-March, and the Illinois session ends at the end of May. So we had a lot of conversations very rapidly. We reached out to national experts, to other states, and put together the bill, which you all will receive a link for, and filed it on April 20th. We had our first committee hearing on April 24th, and I'm sad to say that we actually did not get out of committee. Our bill received 8 yes votes and 2 no votes, but it requires 9 yeses to pass, and we could not get enough Democratic votes. So we're still learning exactly what happened, and we are optimistic that the bill will remain alive. There's not a lot to say right now. This just happened, but we do think that this will hold on, hopefully. We're looking at ways to do that. But I want to share a little bit about what that very short legislative process looked like and what we learned. So in terms of folks who supported the bill, it's not surprising. Patient advocates, consumer advocates, disease groups, providers, they had no problem getting behind this. We also did have support from Blue Cross Blue Shield of Illinois, which is the largest health insurer in the state of Illinois. Our opponents in terms of those who have demonstrated opposition, we only had 5 opponents in committee. The Illinois Life Insurance Council was the only one to testify. So life insurance companies actually sell a lot of short-term plans. So that was important for us to think about. Our bill also addressed the fact that these are not always sold by health insurers, and they're not always sold by folks in the state of Illinois. So life insurers were a big source of opposition, and United Health Insurance did take an official position in opposition. Our Department of Insurance also opposed this bill. We expected this, as our Director of Insurance issued a statement to the press shortly after the federal rules were proposed, saying that they see this as another option for people, particularly those who don't qualify for financial assistance on the exchange. We did not receive any, so the Illinois Life Insurance Council testified in opposition, and I was shocked to see that they said, this is almost a direct quote, "We oppose this bill solely because it limits our ability to rescind coverage for people with pre-existing conditions or to exclude people with pre-existing conditions." So it was shocking to hear that out loud, especially after what we've gone through in the last year. They also opposed because of they essentially said that there's a role for these plans in the marketplace and that people need them in transition. So to that point about SEPs, almost everyone he mentioned is somebody who would need a SEP. Folks have really, in opposition, we've heard a lot of people mention, well, when somebody can't afford COBRA, they need something. And we've had to help people understand that if you're being offered COBRA, that means you're losing minimum essential coverage and would qualify for a special enrollment period. We haven't heard a lot of policy concerns otherwise for us to respond to, so we think that the real need, and if we were doing this all over again and had more time, is for just a ton of education on how the ACA helps people get high-quality health insurance and how limited short-term plans really are. So I would encourage folks to think about that if you're considering legislation. We've also been trying to highlight that these plans are circumventing consumer protections that policymakers have been heavily invested in. We've had a lot of work lately in Illinois, as I'm sure in other states, about mental health access and prescription drug coverage, and this really just undermines all of that good work. Finally, in our messaging, we've really tried to refer to these as junk policies, as opposed to talking about them as health insurance, because we do not believe that as these plans are currently structured, they are health insurance, and we don't want to have anybody get confused about that. In terms of how things are going, like I said, we're looking at a number of opportunities to keep the bill alive, and I'm feeling pretty optimistic today, which is good, and hopefully we'll know a lot more in the next 2 days. And we are trying to really bolster our communications about this. Stories are proving to be essential. Stories are also really hard to find because these markets are small. So far, we've had the best success finding stories by working with disease groups. So I would encourage you all to think about groups like the American Cancer Society, the Diabetes Associations, other disease groups. HIV and AIDS advocates have been really helpful to us to find those stories and start media buzz as early as you can. Broad education on these issues is really going to be helpful. We also encourage you to know exactly who is selling short-term plans and how. To points that were shared earlier, these are coming from associations and trusts and plans outside of your state. And so it's good to think about that as you're writing the language to make sure that you're not leaving a huge loophole for people to walk through. And finally, really think it's helpful to find existing marketing documents to help you think through how these plans work and how they talk about themselves. Also really helpful as education points, because anybody who says this might serve someone well in a transition is not aware of how many reasons these plans provide to not pay claims when the time comes. So we think that that's really helpful. And actually, finally, I want to reiterate the importance of talking about SEPs, special enrollment periods. People really think that these are transitional plans and that people still need a lot of help in transitions, but we know that many folks are going to get higher quality coverage through the exchange or through Medicaid in those transitions. So that's what's going on in Illinois, and I'm hopeful that by the end of May you'll all see all kinds of things celebrating that we've passed a bill here in the state.
Kathy, thank you so much for that overview and the really hard work you all are doing in Illinois to protect consumers from these plans. We're getting close to the end of the hour, but I want to mention one question we received, which was basically just about the timeline for advocacy in the states around these issues. And so, your own state's legislative session will determine a little bit about how much time you have to move forward to get legislation in place this year on these plans, although I will note that there's been a lot of advocacy from many stakeholders urging the federal government to have these plans, broader rules, not take effect until 2020. Of course, we don't know how they will react to that, but even the National Association of Insurance Commissioners, which has been a little bit neutral on this, as Kathy mentioned, some commissioners are actually in favor of these plans. They even have commented that they need more time to figure out how these will work in the market. So I would still encourage you to be in touch with your legislators, no matter the length of your legislative session this year, because even if laws were passed next year, they would still mean a lot. In terms of insurance regulators, now is a great time to be talking to them about this. As hopefully our webinar made clear, there are a lot of different things that can be done to protect consumers from this, going all the way from making these plans banned in the state to just strengthening disclosure. And so insurance regulators will have authority to do some of those things on their own. For others, they might need laws. But even things around better disclosure, doing really strong oversight to look for really egregious violations of state laws, something you can talk to your regulators about now. You can also talk to your governors and even your members of Congress about making sure that they're weighing in about concerns to the White House. Even though the rule comment period on this has closed, powerful figures making calls into the White House and the Office of Management and Budget, the office that has to review the regulation, can always make a difference. So basically the answer is now. Talk to folks in your insurance regulator's office. Talk to folks in your legislature. The plans could take effect whenever the rule is finalized, but now is the time to influence that, and perhaps we'll have even more time if we're lucky. And so I really do want to thank everyone who joined us today, both our excellent speakers and all of you who are very engaged on trying to think through how we can best protect consumers from both the threats to short-term plans and the other things that we discussed today. You're going to receive a follow-up email with all of the resources and materials we discussed today. And you can also visit familiesusa.org, where you can find a number of the resources we discussed. And the last thing I'll say is just look for information in your inboxes about our next Health Action webinar, which will take place in May. If you're on this webinar, you're likely receiving our Health Action emails, but if for any reason you're not, please do visit familiesusa.org. You can type your name into the box that says sign up for our email list. You can also always visit us on Twitter, and you can email us directly if you have follow-up questions at info@familiesusa.org. For the last few questions that we didn't get to answer today, we do have those saved in the chat box, and we're happy to respond to them online. So thank you all so much for your very active participation today. Working together as a community, there's a lot we can do to protect consumers in our states, and we look forward to working with you on this further. So have a great afternoon, and thanks again. Bye.